Yes.
All right, let's go. So welcome. Today is my rather long-winded attempt to answer the question you will inevitably be asked: what is PM&R? My name is Gautam Malhotra. I work full-time at the VA and enjoy a part-time private practice. I'm a graduate of this very same program where I'm now a clinical professor, actively teaching at the bedside and didactics of general physiatry and electrodiagnostic principles. I genuinely love helping and meeting people, so feel free to reach out to me with any questions anytime. So do you remember the slideshows people gave you about med school? They probably looked something like this. now that you've been through a good portion of medical school, I think you'll agree with me that these images are true, but they're not the whole picture. And you're not going to have any idea until you're actually in it. This is perhaps a more complete picture. The curriculum, enormous complex pathways and lists to memorize. Similarly, I think you'll appreciate that you can't understand a specialty of medicine until you're into it. So this lecture's purpose is to help you get in it. There's a lot on these slides, but focus on my voice and just let it all wash over you. Let's academically answer the question, what is PM&R? So it's amazing that all our friends training in other specialties, they don't face this question. In fact, if you Google their specialties for images, the first hits are right on the money. But when you Google PM&R, you get a picture of a physical therapist and this generic guy wearing a stethoscope. Clueless. It's not limited to the internet, though. I think our field is uniquely unknowable by everyone, including our patients, medical students, and even us until there's purposeful inquiry. So I remember telling my study buddies, why didn't they just show us all of this on the first day? A lecture on everything. It would be a seamless coverage of what we are and how we got here. The muscle as our organ system and everything that can go right and wrong with it. This leads to cardiac, pulmonary, vascular, and mobility rehab. Then we'd hit cranial stuff, spine stuff, outpatient topics, and everything that didn't fall into those. So just to really get the informality going here, I would like to get us all on the same page and address the elephant in the room. I can confirm that these are all questions I've been asked, and you will too. With regard to what makes me different from a physical therapist, by the way, my dad, a physician himself, actually asked me that. It's like your primary who prescribes a specific medication, dose, and schedule for taking it for your blood pressure. But he doesn't actually make the pills or dispense them, right? Similarly, I figure out what's going on with you, prescribe what the therapist should dispense. Pain management is a subspecialty that can be pursued by anesthesiologists and PM&R docs. They learn where to put needles up and down your spine. I don't do that because I'm a general physiatrist. Orthopedics is a surgical field that focuses on bones, joints, ligaments, and tendons. Neurologists look at brain, spinal cord, and nerves. These days, they do a lot with vessels too. Physiatrists overlap these two fields, and we're probably the only ones preoccupied with muscle too. Ultimately, we're here to restore function, whether it be the athlete who needs to be able to get back to dunking, the warehouse employee with back pain, or the little old man who had a stroke. We figure out their optimal functional level and use every non-surgical evidence-based trick in the book to get them there. So where did this field come from? For the physical medicine side of things, there is evidence that physical agents were employed in ancient times. Heliotherapy is lying in the sun for heat, and hydrotherapy is using water for wounds and pain. These got more sophisticated as the tech got better. The rehabilitation part can be traced to wars, where they discovered that you could get a soldier back to the war zone quicker with exercise than just sitting around the radio playing cards in a sanitarium. Although there are tons of people who should be on this slide, these two seem to get all the credit because they were instrumental in getting the field recognized when no one wanted to adopt us, including the leaders of internal medicine and orthopedics. We learned a lot about the administrative evolution when Dr. Cruzen's personal journal was made available. It's really no surprise that we still have to explain ourselves when you realize that compared to the other medical specialties, we're among the youngest to be recognized and organized. In 1938, we got called physiatrist to identify the physician specializing in physical medicine. They wanted us to say physiatrist to avoid confusion with psychiatrist, but everyone just says physiatrist anyway. Dr. Dillingham took a stab at a definition. It's wordy, but it really does a great job. We don't perform surgery and aren't limited to one kind of treatment. We can be consultants, inpatient primary providers, or team leaders. So there's a lot in this slide. I'm sure you'll look at it when you see the recording. Dr. DeLisa's textbook goes deeper and asks more of us. We should be comprehensive and address prevention, increased independence, and improved quality of life. We use every trick in the book. What we do should permeate the entire healthcare system. Dr. Joel DeLisa dedicated a good portion of his professional career on advocating for and progressing PM&R, in addition to optimizing the Kessler Rutgers residency program where I trained. His textbook was indeed a force to be reckoned with. Although most of us agree that PM&R doesn't own a particular organ system, Dr. DeLisa proposed that muscle is our organ system. It is truly involved throughout the continuum of our diagnostic and therapeutic world, whether it be brain injury, spinal cord injury, amputees, pain, sports, or neuromuscular medicine. So let's dive into this organ to perhaps gain a better understanding of our field. Now, listen, I could give you a bunch of pictures like I showed you in the beginning of a guy in a wheelchair and a doctor smiling at him and looking at him and being happy, but I really don't think that gives you the flavor of what we actually care about. And so if it's hard science and it seems like really, does he want to show me all this? Yes, I did this on purpose, okay? But you can always interrupt and ask. Oh no, there's a cowboy on.
Can I interrupt for a second? I'm curious what pictures you put on at the beginning and if I'm going to have to fill out some paperwork.
No, I left those slides out after going over human resources, and also Sparsh felt they were only comfortable for his hard drive.
Excellent. I appreciate that, my friend. I'll go mute myself.
All right, sounds good. So the purpose of muscles is to move and or stabilize bones. So here you see a bone, and the tendon is a non-contractile tissue that attaches the bone to a muscle and transmits force or tension to the bone. The muscle belly is what we see with our eyes, and it has a name like biceps. Each belly is a bundle of bundles called fascicles. The fascicle is a bundle of muscle fibers, each of which is a single multinucleated muscle cell. The cell is packaged with these myofibrils, which themselves are comprised of filaments. So in medical school, first 2 years, you saw these thick and thin filaments repeating under the microscope. Each segment is called a sarcomere and is the muscle's histological unit of contraction. If we look at a sarcomere, the way the muscle shortens is that the thin filaments interdigitate with and slide along the thick filaments. This is called the sliding filament theory. For this to happen, when calcium attaches to troponin, it moves tropomyosin out of the way so that myosin can interact with actin. This is called the power stroke and obviously requires ATP energy. So if we're moving, we need energy, and that basically means ATP or other phosphates. There's a whole bunch of that just sitting around in the muscle, and that gets used up first. As you continue moving, glycolysis converts sugar to energy. This is anaerobic metabolism. And if you keep moving, mitochondria can use the oxygen to squeeze out every last bit of energy from the byproducts of glycolysis. The yield of this aerobic energy is phenomenal compared to anaerobic. So the more your muscles can use this aerobic oxidative process, the more efficient the system is at doing work. We'll talk more about this when discussing exercise, but after a certain point, there are only so many mitochondria, and more work is just powered by the anaerobic systems after that. So that was probably the fastest summary possible of what you learned in biology and histology, and there won't be any more of that. So now we can talk about neurons. Whether the muscle fiber is going to be good at using oxygen or not is determined by the motor neuron that innervates it. One way we can determine this is by staining them. Type 1 fibers have lots of oxygen using mitochondria and citric acid cycle enzymes. Type 2b fibers pretty much use only glycolysis. And then type 2a are somewhere in the middle doing both. There are a bunch of muscle stem cells lying around waiting to help out in case of injury or exercise. Those are your type 2Cs. And when staining, we get this beautiful mosaic of interposed type 1s and 2s. But if a motor neuron is damaged or dies, its neighboring motor neuron will collaterally sprout to adopt the orphaned muscle fibers. Unfortunately, we lose the mosaic when this happens, and this is very clinically relevant. So muscle makes an enormous contribution to the body mass. Other than movement, it also offers protection, heat, and energy production, metabolic regulation as well. But today, what we're really interested in is in the generation of movement and force. So let's get to the good stuff now. In my mind, you have normal muscle, the way I just described it for you. But if you do stuff with it, you get stuff. And my goal is to define all of that for you in a practical way. Dynamic exercise will lead to aerobically conditioned muscles. Lifting weights and push-ups will lead to strength. And stretching will lead to better flexibility. On the other hand, this slide is the essence of PM&R. If you don't use it, you lose it. You'll notice I've put some familiar forms of inactivity here. Inactivity leads to deconditioning, weakness or loss of strength, and contracture or loss of range of motion. Physical inactivity is the fourth leading independent risk factor for death caused by non-communicable diseases. Let's start with one of the easier concepts. If you stretch, you get flexibility, and if you don't, you lose it. So these terms may initially seem interchangeable, but they mean different things to a physiatrist or a therapist, and I'm not going to define them for you here. Believe it or not, there are lots of ways to stretch. Passive is what you normally think of as stretching, but you can also stretch while firing the muscle. You can also stretch while getting help from a therapist. You can use repeated movements. So this is all good stuff. But what happens if we don't move? Contracture is compromised motion, and it can be due to lots of things. Joints can get hurt or locked up. If you don't get the normal loading, unloading, and motion that cause the synovial fluid to suck and squeeze like a sponge to offer nutrition, like say in this rabbit who was immobilized for 6 to 12 weeks, the bones become degenerated like someone with bad arthritis. So not moving is bad for joints. Contracture can also occur if the connective tissue or skin congeals up. If you don't move, the connective tissue surrounding the muscle shortens, and eventually, slowly, the muscle loses sarcomeres, contributing to contracture. So that's the good and the bad of motion. Let's talk about strength and weakness from a muscle perspective. I'd like to clarify some vocabulary about muscles generating force. When force is generated quickly, it's called strength. And when you fail, it's called weakness. When you can do it many times or over a long period of time, it's called endurance. And if you can't, it's fatigue. Depending on the changing length while muscle generates force, contraction can be isometric, concentric, or eccentric. When you use a machine to enforce a constant speed of motion, that's called isokinetic contraction, and it's only really used for research. Most of us measure static strength with manual muscle testing, right? You're 5 out of 5, 4 out of 5. The 1 repetition maximum is the max weight you can lift once and then fatigue out. That's called maxing out, right? When you're in the gym. So prescriptions for strengthening can be based on percentages of this, and you can use various equipment to objectively measure strength. We call it resistance exercise when strengthening the muscles by lifting weights or using machines. Using higher weights is more effective, but if someone is injured or really debilitated, you might opt for low weights with more repetitions. Progressive resistive exercises, or the DeLorme protocol, starts by figuring out your 10 repetition maximum weight. That's the amount of weight you can just lift 10 times before fatiguing out. You can use that to then figure out 50%, 75%, and full amounts of weight for 10 reps each. Variations exist like the Oxford, DAPRE, and pyramid training. This is all stuff like your gym rat friends can tell you about. I've included a summary of the American College of Sports Medicine guidelines for healthy folks as well. The early strength gains you see after lifting weights are really a reflection of optimizing your motor neurons in the brain, spinal cord, and periphery. I'm showing the rockets kicking together to convey how much stronger we get when our neurons similarly fire in synchrony. As resistance training proceeds, the various myofibrillar proteins ramp up in production until the muscle cells start bursting at the seams. Those type 2C stem cells that we mentioned earlier also contribute to hypertrophy. The 2B cells start building more oxidative machinery, collateral blood vessels grow, and transcription of glucose transporters increase to make exercise Mother Nature's metformin. Eventually, you get more sarcomeres and stronger connective tissue for better force transmission. How about the opposite? So if you don't move, disuse atrophy occurs. With immobilization, bed rest, you immediately start preferentially losing sarcomeres in your oxidative anti-gravity muscle fibers. The collagen doesn't break down. So with loss of muscle but maintaining collagen, you get stiffness. This contrasts with atrophy from nerve injury, which I showed you before. Contrasts with myopathy, where proximal muscles tend to be affected more. What about just getting older? Well, at this point, we think it's a combination of the disuse issues and less of the youthful stimulating factors in the body. So, let's dive back in now. So, since we're talking about weakness, I just want to digress for a moment and acknowledge that let's just assume you're going to be physiatrists. Weakness means something completely different than it did on your medicine rounds. There were a ton of things that you were looking for before that are usually already ruled out before we see them in our clinics. Clinically, my general approach is to systematically work my way from proximal to distal along the neuraxis. We'll get into detail about this later. Oh, this is the neuraxis. Finally, we get to cardio. Since this can be a difficult topic to navigate at first, I'm hoping to somewhat simplify the literature on this for you. Cardio is really called dynamic exercise. which is any repetitive rhythmical movement of large muscle groups, and it should be enough work to overcome your muscle's aerobic ability. It should be often enough to turn on the genes, ideally daily. It's only going to benefit the muscles that are worked out. Basically, you have to break a sweat. You can measure the intensity by looking at a heart rate, asking how hard they think they're working, or by the settings on the machine. There are 3 parts to a workout. Start with a 5-minute warm-up to get your blood flowing and loosen up the joints. Then you do the hard work for about a half hour. Finally, don't just stop, decrease to a mild pace so that you don't get venous pooling. When my wife and I first went back to the treadmills in the gym, we stopped after 30 minutes of being on the treadmill. And I said, babe, are you dizzy? She said, yes. I said, turn the treadmill back on. That's called venous pooling. The blood that should be going to our brains is hanging out in our legs. That means we're out of shape. So it's a thing. Anyway, I just want to orient you to these curves where the x-axis is how hard you're working and the y-axis represents how much oxygen your body is consuming. As you can see, this is a linear relationship and plateaus at a certain point. When looking at these graphs, always start on the left at rest when your body is at its lowest metabolic demand. Then see what's happening all the way to the right, which is the maximum workload. This is when your mitochondria can't make use of any extra oxygen that the heart is sending over. This is called your aerobic capacity or anaerobic threshold, and it's what we want to improve with conditioning exercises. Everything in between these extremes is called submaximal exercise. So here's the story that no one tells you about exercise. During a bout of exercise, your muscles need oxygen and energy to move, so the vessels to the muscles open up nice and big. This decreases peripheral resistance, so less blood is sent to the gut and kidneys because we don't need to pee or digest right now while we're exercising. The autonomic nervous system kicks in to get your heart beating faster and harder. This keeps increasing until you max out. A lot of the energy used by the muscle is released as heat through the skin. So imagine this in our advanced neuromuscular or cardiac patients. It certainly might raise some concerns. That's why it can be a good idea to get a baseline exercise tolerance test to see how much they can safely tolerate. Briefly, there are all sorts of ways you can test them. Then you can create an individualized exercise prescription, allowing an optimal level of training without exposing the patient to undue risk. So you're a good girl and follow your prescribed regimen. You'll get more blood vessels to the muscles, better insulin sensitivity, and best of all, more mitochondria and more optimized mitochondria. I'm sure you already know all the benefits of exercise already. The cardiovascular benefits are that your maximum aerobic capacity and cardiac output increase, so you can do more work with the oxygen you're given, and this puts less demand on your heart. And yeah, you feel good too. Now the bad news. If you don't move, it's awful. All of your body systems are jacked up, as you can see from this table on the left. So body's jacked up, as you can see from the table, and you get osteoporotic, orthostatic, swollen, ulcers, Chem7 out of whack, constipated, ventilation perfusion mismatch, sleep disturbance, compression neuropathies. And the muscles we kind of already talked about, but it's bad. This diagnosis of deconditioning does not exist in the ICD for some reason. So when all of this happens, it's called deconditioning. It's your body's normal reaction to not moving, to not use resources when they're not needed. In the early 1900s, people were put to bed rest. Based on what we know now, I tell my patients that bed rest is poison. And unfortunately, many of our rehab populations are afflicted with this in addition to their other diagnoses. So this was my whirlwind presentation of exercise science as it will relate to the neuromuscular research out there. It essentially boils down to the body having a continuum of responses to the type and amount of activity it's exposed to. But that was some hard science there, and it's very applicable to how we counsel our patients. All right, so we could take a different directions. If you take the stuff I just taught you and apply it in the context of a particular disease process or setting, that basically is what we call rehab. So if you use exercise in the context of cardiac disease, it's cardiac rehab. Pulmonary or vascular disease, pulmonary rehab and vascular rehab. Of course, I'm oversimplifying, and you need other things like these. But perhaps the most important component is that it's interdisciplinary. Or do we mean multidisciplinary? In fact, do you guys know what the difference is between those words? Don't worry, most people can't articulate the difference. Basically, everyone stays within their boundaries when multidisciplinary, while interdisciplinary, people work together in a coordinated fashion. So for example, your inpatients, it's multidisciplinary. Cardiology comes in the bedside, sees something, writes in the chart. Pulmonary comes in, they write something, sees things in the chart. But when we're doing this in an interdisciplinary fashion, we all actually meet and say, all right, do we all agree on the diagnosis? Yes. Do we all agree these are the goals? Yes. Do we all agree that this is how we want to do it? Yes. And lots of benefits come from being interdisciplinary. So you can use an interdisciplinary approach to restoring function in the setting of cardiac disease. It becomes cardiac rehabilitation. Indications are on the left and contraindications are on the right. Let's look at the actual cardiac rehabilitation steps after having a heart attack. The goal of the first phase is to expedite the hospitalized patient home safe and independent. Early mobilization and education starts in the CCU, and ambulation progresses on the wards. For a month, you want them to just take it easy at home while their infarcted myocardium scars over. Then we exercise them for a month. Finally, lifestyle changes have to be maintained in order to reap the benefits. How about obstructive pulmonary disease? You all know that COPD is progressive dyspnea and deconditioning due to irreversible obstruction of the vessels and airways, usually attributed to cigarette smoking. Better than me, you know that they should be treated with meds, oxygen vaccinations, and counsel to stop smoking. All of that plus exercise in an interdisciplinary setting is offered with a pulmonary rehabilitation program. Along with respiratory therapists, we teach energy conservation and secretion clearance techniques. Now, all of this pulmonary rehabilitation will not change pulmonary function tests or mortality, but there is improvement in walking, ADLs, dyspnea, and decreased hospitalizations. So remember this, when you see all these people as an intern, these could, if you implement these, you could decrease the number of admissions you have if they had pulmonary rehab. So I just want to make one nuanced comment. Although cardiac and pulmonary rehab are essentially doing the same interventions, the reasons are different. We're optimizing the skeletal muscles in the periphery to be more efficient and require less oxygen in order to decrease demand on the heart. Whereas with pulmonary rehab, we want to optimize function because the lungs are doing a cruddy job. We're not worried about infarcting the lungs. We just want to do more with less. This is the same thing with vascular rehab. As you all know, especially in smokers, blood vessels can get blocked up and cause claudicating leg pain. There are med surgeries and invasive procedures that can be offered, but you can also exercise them to increase their muscles' ability to do more with less, just like with pulmonary rehab. They have to frequently push through the pain to get any benefit. Unfortunately, many of them will require amputation when other treatments have failed. So this is a nice segue to amputee rehab. As a physiatrist, you may be needed for pre and perioperative issues, but the bulk of our care happens postoperatively, where goals are optimizing pain management, wound care, and preparation for a prosthesis. Very often, we develop lifelong relationships with these individuals. The prosthetic and management options are highly dependent on the level of amputation. You'll see many transfemorals or above knee, transtibials or below knee, and then there's partial foot amputations. There are other rarer levels such as hemicorporectomy, where half of the body is ambitiously removed. You're going to learn lots of new vocabulary, and you've already heard me say prosthetic. That's the adjective form of prosthesis. This is a device that replaces a part of the body. So you can have a prosthetic valve or eye in addition to a limb. An orthosis is a device externally added to the body to enhance function and or add support or stability. Learning all of the different options can be challenging. With partial foot amputees, we usually alter their shoes and offer fillers for within the shoe. But anything more proximal requires that you understand the categories of componentry comprising a prosthesis. They're mostly constructed with some kind of pylon, which is also known as endoskeletal construction. Anything touching or interfacing with the amputee is part of the socket. Whatever keeps it on is the suspension, and then we have the various joints. Sockets are fabricated by a prosthetist, plaster casting the limb to create a replica of the residual limb. They can then stretch a thermoplastic sheet over it for total contact with different shapes of compression and relief depending on the pressure-sensitive and pressure-tolerant areas of the limb. The above-knee amputee has different challenges with regard to socket design than the BKA, and sometimes the socket will include a liner for comfort, protection, or even help keep the device on the limb. Ensuring the prosthesis stays on the below-knee amputee can be done with flexible options like neoprene sleeves, leather cuffs, above the condyles, gel locking liners, or waist belts with fork straps. The other type is to build it into the socket so that the trim line grabs above the condyles or the patella. The above-knee amputee suspensions are similar with suction, with traditional gel locking liners, or fancier ones. Non-suction options include a leather belt, a neoprene sleeve, and sometimes more durable hardware. Above-knee amputees will need a device that replaces their knee, These use locks, mechanical hinges, hydraulics, and even microprocessors to balance stability with functional mobility. The simplest foot is a block of wood with a cushion in the heel. You can add hinges, allow conversion of stored potential energy at the start of a stance with kinetic energy, simulating plantar flexion at terminal stance, and we can put computers in ankles too. The purpose of all of this is for them to achieve functional mobility, participate in recreation, and achieve a sense of wholeness in the context of limb loss. Just as an aside, upper limb amputee can also be approached similarly, but carries a host of other issues that make them challenging to rehabilitate. They can operate their hands and elbows either with body-powered or externally powered systems. Sophisticated cosmetic techniques continue to achieve more realistic-looking hands and fingers. Not only will you scrutinize your amputee's gait patterns to identify ways to optimize their prosthesis, but I would argue that you'll probably observe the gait of every patient you see during training. Although deep dive investigations into gait can occur at a gait lab, observational gait analysis is quite powerful as well. You'll learn all the phases of the gait cycle, how the body's center of mass propagates and contributes to the ground reaction force. You'll learn when all of the muscles at each joint are contracting and if they are concentric or eccentric during the gait cycle. You'll learn how the determinants of gait contribute to the smooth gait in nature rather than walking like an action figure doll. There is a little physics in play, and just like Neo in the Matrix, you just won't be able to unsee it once you learn it all. Depending on the existing deficits, you might prescribe assistive devices to promote safe functional gait. Canes can have different shaped handles and can contact the ground with single or 4 tips. The white color of a visual impairment cane should be familiar. If the 4 points need to be really wide, you can prescribe a hemi walker. A standard walker gets picked up to move, while a reciprocal will act like an inchworm. Some will need forearm support due to hand issues. Kids will usually do better with an opening at the front, and they even make one to climb stairs. The majority of my elderly deconditioned patients need what we call a rollator with a seat and handbrakes. Another type of are crutches, which can allow more support to avoid a wheelchair. You've all seen axillary crutches. The forearm crutches offer a safe, easy substitute for a cane, but they're less stable than the axillary. Platform crutches allow unloading the painful arthritic hand or wrist. The 2, 3, and 4-point gait patterns offer progressive stability while sacrificing speed, while the swing-through gait gives faster speeds than even normal gait. People with gait issues may sometimes need something attached to offer support of their limbs. The AFO is probably the most prevalent for ankle-foot stability. Work your way proximally to provide more stability to the knee, hip, and trunk. Ultimate safety with mobility comes in the form of a wheelchair, which you will learn to prescribe by learning all of its components. Each of these are customizable to the individual diagnosis, needs, and lifestyle of your patient. Whether they be a high tetraplegic public speaker, double amputee athlete, or 100-year-old veteran who just wants to get around easier. If they can't propel themselves and they're competent to handle it, we can add a motor. Scooters have become ubiquitous, but they aren't great in the setting of disability. You can add a motor component to an existing wheelchair to turbocharge their own manual propulsion. And powered wheelchairs are where you can do all sorts of seating customization, add-ons, and cool interfaces like joystick, sip and puff, or head arrays. In addition to mobility, we can help with other challenges to the activities routinely performed throughout the day, no matter the medical condition. When laid up, fully electric hospital beds can help make the position changes easier and provide pressure relief. We can offer lifts for getting in and out of their furniture and save their caregivers' backs. Toileting can become difficult despite retaining bowel and bladder functions. Some may even limit their oral intake in the hope of requiring fewer trips to the commode, as it can be very stressful activity. So simple techniques and equipment can address this. When bathing becomes challenging, bathroom modifications and specialized equipment can change their lives. A mobile arm support or balanced forearm orthosis can be beneficial for patients with proximal upper extremity weakness. Built-up utensils, angled shape, play cards, rocker knives, lightweight mugs, these can all be helpful for self-feeding. And techniques and adaptive equipment facilitate efficient dressing with less energy consumed. In PM&R, we love our equipment. You'll recall I said we'd return to orthoses, which we defined as a device externally added to the body to enhance function and or add support or stability. This is essentially done by exerting force on the body at 3 points as shown in the figure. This can be applied to the shoulder, elbow, wrist, hand, metacarpophalangeals, interphalangeals, and have simple to complex mechanisms to aid in function. For the lower limb, we prescribe these quite often, such as with patellofemoral syndrome, or if to prevent hyperextension, protect the ACL, compress or unload the painful joint, protect a surgerized knee, or improve the motion after an inadequate surgery. You'll learn what to put inside a shoe to create a certain effect on the foot, ankle, or knee, and even learn the parts of the shoe which you may prescribe alterations of as well. So that's a nice place to pause, just to round out the picture of who I am. This is my family, my colleagues, my Bitmoji, the Optimus Prime costume I made for Comic-Con, me with Weird Al Yankovic and some silly stuff. This is just so you know that I'm a people person underneath all the official medical stuff. So now it's time for us to interact, stretch, and for me to pull up the next presentation.
Welcome to part 2, the central nervous system stuff. Here we'll hit everything sitting in the skull and spine. For the brain, there's a lot we can address as physiatrists. Needless to say, the brain is a complicated organ both structurally and functionally. You're going to learn the lobes, established functional regions, the meninges, flow of cerebrospinal fluid, and also the major blood vessels. Vessel problems of all kinds, bleeds, clots, or perfusion-related, can lead to profound functional disturbances collectively referred to as strokes. Stroke is the clinical presentation of disturbed cerebral function attributed solely to vascular issues. How they initially present depends on which vessels are involved. You'll see different syndromes that correlate with the compromised portion brain tissue. On your inpatient rotations, you'll be surprised at how familiar you become with these, but unlike during your neurology rotations, how they present will occupy less of your time than how they recover. The majority will start in an acute care hospital and then be transferred to a facility such as acute or subacute rehabilitation, or discharged to home with outpatient therapy or visiting therapist. The rehab units are sometimes located inside the acute hospital, but often are found as separate facilities. Subacute rehabilitation similarly may be standalone, or they may be housed within a skilled nursing facility. These have many names, but most people know them as nursing homes. Optimal choice for rehabilitation with these facility options depends on severity of the stroke neurologically, but also the associated problems, which are many, as shown in the slide. You don't stop being a medical doctor in PM&R. In fact, you're going to develop the expertise of dealing with these not so bread and butter issues, as this is what makes us physiatrists on the inpatient side of things. But let's get back to function and mobility. Neurosurgeons and neurologists really won't have the practical prognostic data that you're going to have. The patient's expectations regarding walking will be set by conversations you have. Initially, you'll lower the seat height on their wheelchair to allow for leg propulsion, encourage the use of the unaffected side, and progress to walking with braces and assistive devices. You'll also be the one helping the stroke victim navigate functional restoration, pointing out milestones, and working with the team to guide and expedite recovery. Most of the motor recovery occurs in the first 3 months, and there are accepted and very well delineated stages that require adapting. The proximal muscles improve first with increased tone before volitional motion, and it is synergistic before isolated movements come back. Generally and overall, if the vision, bladder, or communication deficits don't recover within a month, you can expect slower overall recovery and deficits lasting longer. Bigger lesions may be worse than smaller ones. 90% of stroke survivors will have some neurodeficit, but most will regain functional independence, while up to a third may be permanently disabled. It's useful to think of restoring function as either a consequence of neurological recovery or strategies to compensate for the lost function. For example, your right hand extension weakness after stroke may recover due to healing in the brain, or you may have to compensate with a brace or compensate by using your other hand. Rehabilitation has been proven to be beneficial in all stroke severities, especially if it's early on and intense. There are a number of different established approaches to trying to facilitate neurological recovery that the therapist will choose based on experience and the patient. And we're constantly coming up with cool new ways to do this, including neuroprosthetics, robotics, and interactive virtual reality protocols. They routinely learn the compensatory strategies and are trained with equipment to compensate for function that doesn't return from neurological recovery. Stroke patients have plenty of overlap into the musculoskeletal outpatient domain where they develop the so-called stroke shoulder. Initially, the ball flops around in the socket while flaccid until the reverse occurs with the increased tone. Eventually, this can unfortunately progress to the shoulder-hand syndrome, which can be challenging to treat. The brain can also acquire functional deficits by direct or indirect injury. Trauma to the head can occur with car accidents, falls, and projectiles, creating an opening in the skull or not. This is the primary injury. The severity is often classified based on the Glasgow Coma Scale of eye opening, verbal, and motor response. Loss of consciousness and amnesia durations are also used. A mild brain injury is also colloquially called concussion. Briefly, you will encounter mild brain injury or concussion in the context of pediatric and adult athletics, motor vehicle crashes, and military blast exposures. The grading and categorization can be challenging to wrap your head around. However, the ones where imaging shows a lesion is more straightforward. Primary injury can be focal or diffuse. Focal injuries can be penetrating, yikes, or non-penetrating, which we call contusions. These are most common in the anterior temporal or orbitofrontal regions, regardless of site of impact. There will be damage from the initial impact and then a second impact, which are respectively called coup and contra coup injuries. These exert effect via hemorrhage, edema, tissue distortion, scarring, as visualized here. The other type of injury is called diffuse axonal, which is a twisting and tearing of axons arising from rotation of the brain around its axis. This affects midline structures and is associated with coma. Secondary injury is the process of delayed cell death due to a cascade of events. Although way beyond the scope of this intro, I take great pride in being able to summarize this in one slide. Suffice it to say that lots of consequences of damaged neurons cause swelling, which can lead to herniation and death. To make matters worse, brain tissue is particularly vulnerable to oxidative injury in the first place because there's a baseline high rate of oxidative metabolic activity. Neurons are non-replicating and a few other geeky pathophys things that lead to an unpleasant situation. There are some known neuroprotective pathways including neurotrophins, adenosine, and lactate conversion. Various changes in consciousness occur after brain injury, including coma. This is defined as a state of pathological unconsciousness in which the eyes remain closed and there is no evidence of purposeful motor activity. Vegetative state typically follows where there is some form of eye opening but without any responses to the environment. A minimally conscious state is the condition of severely altered consciousness but in which there is definite reproducible evidence of self-awareness or environmental awareness. You're going to learn the many ways to measure these states. Rehabilitation can be more challenging if they carry another diagnosis. Many will have seizures, cranial nerve injuries, and fluid imbalances. Mental health and many of the issues mentioned for stroke abound in this population as well. Although healing does occur to some degree, there are other mechanisms at play. These concepts are quite interesting, such as the idea that one area of the brain affects another, or that they can substitute for each other through plasticity. Stroke and brain-injured patients will work extensively with speech and language pathologists. These are highly trained therapists that deal with three things. Speech is the process of producing sounds functional for communication. Language requires manipulating these sounds to the rules, meaning, social aspects of communication. These therapists are also very much involved with restoring functional swallowing when there's an oral, pharyngeal, or esophageal issue. This is a chart from when I was a med student on thinking about communication issues. You can have conduction or sensory neural hearing loss, difficulty receiving, processing, or forming thoughts, issues with sound production or articulation in the mouth. Aphasias are disorders of understanding thought and word finding. These are usually seen with dominant hemisphere lesion. These are your Wernicke's, Broca's, conductive, and transcorticals. The word dysphagia, sometimes used for disorder of speech, so that aphasia is reserved for absence of speech, but I wouldn't use it as it could be confused for dysphagia. Other than aphasia, communication can be affected in ways other than aphasia or dysarthria. Speech apraxias are the inability to do learned skills. Agnosias are the inability to recognize. Similar to other issues in rehabilitation, we can use compensatory strategies and devices to help restore function with compromised communication. Swallowing is necessary for survival. Abnormal swallowing or dysphagia leads to dehydration, starving, aspiration pneumonia, or airway obstruction. It's frequently associated with cerebrovascular disease, traumatic brain injury, head and neck cancer, and other conditions common in rehabilitation patients. Although the bedside eval is the mainstay, you may be supervising video fluoroscopic evals, where you see the juice or cookie going down the wrong pipe dynamically in real time. Scopes and fiber optics can be used when radiographic studies are difficult, with the benefit of directly visualizing the pharynx and larynx. In many cases, swallowing impairments are amenable to rehabilitation treatment. As you can see, there's so many ways to help other than putting in a feeding tube. Hearing loss is quite frequently seen in PM&R, especially in the elderly, TBI, blast injuries, cerebral palsy, multiple sclerosis, etc. Society perceives them as rude or dull and will affect their daily function. As someone with early hearing loss, I can attest to this. Along with speech, your team will now include ENT and audiology, who will employ clinical and audiological testing. As always, rehabilitation includes compensatory strategies and assistive devices like hearing aids and visual cues. These reduce anxiety and depression. Along with hearing, the inner ear includes the vestibular system, which can be severely compromised in the context of brain injury. The evaluation for dizziness or vertigo requires entertaining a broad differential. It can be the presenting complaint with a tumor, and I see a lot of people with benign positional vertigo in my clinic. There are a number of exercises employed to expedite recovery, all of which are collectively called vestibular rehabilitation. Profound vision deficits obviously can severely affect function. There's a lot that can be done, but usually this is offered by a vision rehab team rather than a physiatrist. And finally, just to round out the head, other issues that affect the brain include dystonia, which is a challenging issue for all clinicians, as well as Parkinson's disease and its variants. These are all amenable to rehabilitation while working with a neurologist for optimal medication management. So that's the brain. Here is a comic entitled Life of a Medical Student, which I think we can all identify with. Honestly, the brain isn't where I spend most of my work day. It's in the spine and limbs. And there's so many cool things we can do to help with these issues. The spine is a stack of bones called vertebrae. Between the skull and thoracic are cervical. The ones attached to the ribs are called thoracic. Below that are lumbar. Then there's a fused section called the sacrum, which has an itty-bitty vestigial tailbone. Starting at the top, C1 is a ring called atlas that holds up the skull. C2, or axis, is a pivot joint. C3 through 6 are generic, while C7 is the transition from cervical to thoracic. The lumbar vertebrae look very different from the other levels. Throughout the spine, we have ligaments front to back to limit movement. When atlas loses its connection to the skull, it's called an atlanto-occipital dislocation. This internal decapitation is survivable and usually surgically addressed, but sometimes you might see people placed in a halo if it's due to ligamentous incompetence. When the atlas rings break, it's called a Jefferson fracture or C1 burst fracture. Moving down to C2, if fractures disconnect the front from the back, then it will separate from C3 and you get the classic hangman's fracture. C2's odontoid projects up to the foramen magnum and can also be fractured. Fractures of the typical vertebrae C3 through 7 can be categorized by their mechanism of compression, distraction, or rotation. There are several classification systems for the orthosurgeons to know. In PM&R, we worry about spine stability. You can look at the imaging for sagittal displacement, angulation, jumped facets, but many people use the 3-column model for the spine, introduced by Dennis in the 80s, which breaks it up into front, middle, and back segments. Disruption of 2 or more columns results in instability and risk of spinal cord injury. Similar principles apply to the thoracic spine fractures seen with gunshot wounds and car accidents. I mostly see anterior or wedge compression fractures in the context of osteoporosis. This is a great time to mention that bone is a dynamic structure which responds to and adapts to the loads applied through it. If loading on a particular bone increases, the bone will remodel itself over time to become stronger to resist that sort of loading. If loading decreases, the bone will be adapted and become weaker. It's interesting, gymnasts are seen to have higher bone mineral density than volleyball players, everywhere except for the pelvic bone. Back to osteoporosis. While in internal medicine you spent most of your time thinking about meds for this, there are actually a lot of things we can do in physiatry, including muscle re-education, reduction of kyphotic deformity, mobilization, bracing, pain management. There's good research showing that back extensor strengthening and proprioceptive training with weight-bearing exercises can reduce disability, risk of future fractures, and back pain. Back pain is one of the top musculoskeletal complaints you're going to be evaluating. Globally, it contributes to economic inequality, preferentially affects poverty, and is costly to the system in treatment and lost work hours. We ask a lot of red flag questions because back pain can be the herald of some scary things like cancer, fracture, and infection. After that, we perform an extensive physical examination to determine if there can be or there may be a neurological issue or non-neurological. Simple bed rest can exacerbate back pain because prolonged supine position encourages localized, prolonged, isometric, low-intensity contractions in the back. It's reassuring to know that most back pain gets better in 6 weeks, whether you treat it or not. As usual, muscles don't get enough attention, even though they are so important to offering dynamic stability to the spine. We're not just talking about the little ones attaching each segment to the next, but also the glutes and hamstrings, and abdominals and pelvic floor muscles. Most back pain improves if you address the strength and coordination of these muscles collectively, called the core. The celebrity structure in the spine tends to be the intervertebral disc, which separates vertebrae, offers cushioning, and offers motion. Like a jelly donut, the annulus fibrosus are spirally arranged concentric collagen rings with nucleus pulposus in the center. In addition to those two parts, superiorly and inferiorly are a layer of hyaline cartilage called the cartilaginous end plate. It is adjacent to the vertebral end plate, which is composed of cortical bone. As you can see here, it functions as a mechanical barrier between the pressurized nucleus pulposus and the vertebral bone, and serves as a gateway for nutrient transport via these vessels. Here's a close-up schematic of the bone, cartilage, annulus, and nucleus. Here's a histologic stain and an MRI of the same thing. A disc bulge is when the dough of the jelly donut is out beyond the margins of the bones. Degenerative discs are dried out and smaller. Disc herniations are the ones where the jelly squirts out in varying degrees. If it hasn't made it out of the dough, it's a protrusion. Extrusion is when it has, and sequestration is when it's lost its connection to the parent disc. If the nucleus pulposus herniates up into the vertebra, it's called a Schmorl's node. Disc herniations are seen in a large part of the asymptomatic population. They're constantly herniating and they're regressing spontaneously without surgical intervention. The body probably gobbles it up. And it's interesting because the worse the herniation, the better the chances it'll disappear on its own. So now that we've addressed the patient's, I've got a disc, I want to address the arthritic spine. The word spondylosis for you guys is as good as spine arthritis. It's wear and tear, drying out, spurring, and just plain yuck on x-ray and MRI. This is all stuff we can see in asymptomatic spines, though. So this brings us to a messy term, spinal stenosis. As you already know, technically, the word stenosis means a smaller diameter. It can refer to anatomic findings seen on imaging, but I hear people referring to it as a syndrome or even a pattern of electrodiagnostic findings. So I tried to clarify some of the terminology with this slide. When talking about spinal stenosis, it can be of congenital or acquired etiology. It can be central or lateral. When it is lateral, there are zones that can be identified to further detail it. These are particularly important in radiculopathy. The syndrome of spinal stenosis is the unfortunate neurogenic claudication that comes from a complex set of contributing factors. The classic shopping cart sign is that of an elderly person limited by radiating pain while walking erect, but they can tolerate it when leaning forward. Just below the lumbar spine is the sacroiliac joint, which has a complicated anatomy, biomechanics, and can be the site of pain. Given that Rutgers is the home of the tailbone doctor of the world, it would be deeply disappointing if I didn't point out that the coccyx is the final location of the spine where pain and dysfunction can be addressed. As we previously talked about orthoses as a three-point pressure system, applying forces to support, limit, and stabilize, spine orthoses can be helpful in a number of the conditions we just mentioned. You'll learn the pros and cons that influence prescription, including balancing motion with support and comfort. There are a lot, and they aren't easy to memorize initially because many are named for the guys who invented them. But one easy way is to name it based on the body part it's affecting. For example, cervical orthoses can be used to warm the neck, support it, or totally immobilize it during transportation after a sports injury. Head cervical orthoses will offer even more support, and you'll be seeing a lot of patients with these on your SCI rotations. Extending it down the trunk will offer the most support, and you'll learn how to manage issues associated with the halo orthosis on the right. Descending the spine, you can limit flexion, extension, lateral bending, and rotation at the lumbosacral spine or the entire way down the spine, especially after fracture or post-op. They can be clamshell, custom molded, or prefabricated. And in the outpatient world, you'll be dealing with flexible versions of these. Kids with scoliosis are a special population with a specific set of braces that have been shown to prevent curve progression. These kids aren't thrilled with wearing them all day long, so now there are 3 nighttime versions. Scoliosis is a troubling lateral curvature of the spine that progresses in the growing child if not addressed. It can be due to existing defects, neuromuscular conditions, or for no identifiable reason at all. The prior slide already presented the various braces. Surgical correction is warranted with a Cobb angle of greater than 40 degrees. Otherwise, you can develop myelopathy, which refers to any pathology of the spinal cord, which is a long list, but in my clinic, I'm mainly seeing this due to the arthritic spurs and herniated discs we already talked about. What about if you got a knife through your cord? Or let's say you broke your spine and it severed your spinal cord. That's when we call it SCI, and there's a lot you have to do initially. You have to immobilize their spine and keep them alive as you transport them to a trauma center. They'll be in spinal shock for a while. They'll have surgery in these obvious cases, but it can be a more challenging decision in more nuanced situations. When they've stabilized, you'll give them a diagnosis per criteria by the American Spinal Injury Association, determined by an extensive exam of light touch, pinprick sensation, and manual muscle testing of key muscle groups. Finally, based on their anal sensation, you'll label them with a letter that says how complete or incomplete the lesion is. This diagnosis offers a lot of guidance for treatment and prognostic power. For example, based on the level of injury, there will be a predictable loss of cardiovascular reflexes. Above T1, the vagus dominates without the sympathetics balancing it. Injuries above T6 will affect splanchnics, etc. Blood pressure and heart rate will be out of whack too. Feedback from baroreceptors gets blocked at the level of injury, so the vessels stay dilated and blood doesn't get to the brain. When you're on your SCI rotations, you'll reflexively start elevating patients as they pass out in front of you. This improves over time on its own. But we use a lot of techniques and some meds to help them along. Because spinal cord injury hits all of Virchow's triad, with increased platelet aggregation, increased factor VIII activity, and slow fibrinolytic response, it's no surprise that pulmonary embolism and DVT prevention and management are a huge part of the medical management during acute rehabilitation stay. You'll develop a sixth sense about DVTs and PEs when you're on call. One of the only emergency issues owned by PM&R is the autonomic dysreflexia seen with SCI that occurs above the sympathetics. Essentially, some noxious stimulus like a full bladder or an ingrown toenail can't get and send signals up the cord for us to normally address. So adrenaline and other sympathetics kick in, causing widespread vasoconstriction and hypertension. This is detected by the baroreceptors. So the vagus tells the heart to slow down so that the pressure can decrease, But that's not going to happen until the sympathetics shut down. And that's not going to happen until the noxious stimulus can be removed. Unfortunately, this leads to a pounding hypertensive headache, seizures, and eventually death due to hypertensive hemorrhage. This is where the physiatrist can be the hero by recognizing it, treating the symptoms, and addressing the cause. Diseases of the respiratory system are the leading cause of death after SCI. 72% are due to pneumonia, which is the leading cause of death at all time periods post-injury and highest in tetraplegia. The main problem after SCI is the difficulty clearing secretions, atelectasis, and hypoventilation. C3 through 5 keeps the diaphragm alive and is affected with SCI at these levels. With innervated diaphragm and nothing else, vital capacity will be 1 liter. Below C5 have incompletely innervated intercostal muscles, which decreases the ability to take a deep breath. In all levels, even to T10, secretion clearance is an issue because of weak cough due to abdominal muscle weakness. Paradoxical breathing may be seen in tetraplegics. Deep inspiration results in the abdomen rising while the chest sinks in due to low tone in chest wall and abdominal musculature, and use of diaphragm as only muscle of inspiration. Reintroducing the bladder, normally the kidney filters, concentrates, and secretes, and the ureters carry urine as they tunnel through the bladder wall. Urine sits there collecting until it's time to pee. The bladder wall muscle or detrusor contracts while the internal anal sphincter relaxes in a coordinated fashion. That's peeing. Afferents detect bladder distension, while alpha adrenergics contract the sphincter and beta relax the bladder. Acetylcholine stimulates bladder contraction. These are through the hypogastric and pelvic nerves, while the pudendal offers voluntary control over the external sphincter. The CNS in the anterior pons, cerebrum, and cerebellum also exert some control. So, the point of all this is that after spinal cord injury, neurogenic bladder dysfunction complicates daily function with associated urinary tract infections. SCI will cause loss of coordination between the brain and everything below. Brain problems cause loss of inhibition, so you're always going. If the sacral elements are affected, your bladder just sits and doesn't contract. If one of the nerves is affected, it becomes atonic. One management technique is to periodically self-catheterize. Based on the presenting problems, there are medications which can help as well. The gut has its own inherent nervous system, which is called Auerbach's and Meissner's plexus. The parasympathetics from the vagus and the pelvic nerve also come in, and sympathetics exist from T5 through L2 via the mesenteric and hypogastric nerves. So spinal cord injury leads to a compromised bowel after the initial ileus resolves, and so a bowel program is initiated based on the type of injury. SCI causes upper motor neuron bowel problems, where the combination of compromised propulsion and chronically closed sphincter leads to constipation and impaction. Stool softeners, laxative, fiber, and some digital stimulation. This can program the bowel to get patterned for movement. Lower motor neuron injuries cause flaccidity, which also leads to constipation. The same denervation affects the reproductive organs, which have to be addressed along the way. SCI and TBI both can lead to bone formation where it shouldn't normally. This heterotopic ossification limits range of motion and can be quite painful. As part of the upper motor neuron syndrome, the central nervous system's inhibitory influence is lost. This results in a velocity-dependent increase in muscle tone, which can cause discomfort and affect function. We use the modified Ashworth scale to assess degree of spasticity and have many approaches to treating. As you all know, multiple sclerosis is a debilitating condition due to demyelinating plaques in both the brain and spinal cord. It's a variable and unpredictable disease with many variations on the issues we've already covered. Treating the pain and disease is an active process that neurology usually manages, but sometimes physiatrists have taken this on as well. So let's breathe a sigh of relief as we move on to the final segment of our trilogy. We've covered a lot of general rehabilitation as it relates to deconditioning, amputees, and central nervous system issues. Now it's time to look at musculoskeletal and peripheral neuromuscular medicine. We talked about muscles in depth already, and we briefly mentioned tendon before. Its specific collagenous tissue that attaches the muscle to bone. This family medicine paper shows healthy tendon with the collagen all pristine and organized, but with inactivity, you get degeneration or tendinosis. The term tendinitis refers to acute inflammation, which this does not represent. The encapsulated Golgi tendon organ sits within the tendon, detecting tension developed by muscle contraction, but not detecting stretch. Magnified with tension, the yellow helices here are collagen, pinching the interwoven red 1B afferent axons. This signals for relaxation when sensing overload of the muscle. You'll hear a lot about the spindle too. If you talk to osteopaths or deal with spasticity, you're going to hear a lot about it. It's an encapsulated organ that lies in parallel with the rest of the muscle belly that sends information about the length of the muscle back to the central nervous system. With that anatomy and physiology out of the way, most of my day is spent addressing musculoskeletal issues, which I was basically able to summarize in this one slide. These can affect any part of the body. I rarely see bony fractures or bruises, but I do see a lot of inflammation or irritation of bursae, fascia, tendons, and their attachment sites. I see strains and sprains, and when cartilage defects occur. We have our musculoskeletal syndromes, and there are some major categories to go over. Those of you excited about sports medicine need to understand everything we do and apply it to the athlete. You have to understand biomechanics, development, nutrition, and emergency care. You'll be competing with surgeons and family practice docs when you run out on the field to save the day. Other than these, there are a number of specific pain disorders that can be challenging to deal with. Of these, us generalists get pretty deep into the presentation and treatment of myofascial pain because it is so prevalent in our population. On exam, we see taut bands and trigger points all the time, and we have lots of ways to treat it. There are numerous medications that can be prescribed if you choose to do so, but with the opiate crisis, hopefully many have started moving in a different direction. I've always believed in the osteopathic principle of mind, body, and spirit being connected. Western healthcare systems have increasingly incorporated more non-traditional approaches from the rest of the world. It's getting more complicated as they try to further classify things. We can use needles to poke holes in muscles, bathe them with corticosteroids and anesthetics, and we can do this using landmarks, ultrasound, and x-rays. I do a fair amount of these during my work week as a component of my treatment regimen. In the past few decades, there's been a surge in interest in the ways to regenerate the degenerated tissues. Autologous means take some part of the person's body and put it back in another part of their body. I think the slide says it all, that this is a subject of controversy at this time, but the evidence is accumulating enough that it could stay with us in our future. I just don't think people will be as excited about it when it is FDA approved and they're getting paid by Medicare rates rather than out-of-pocket rates. Many of you will go further for fellowship training in what I affectionately call injectology. These are procedures usually involving the spine with the goal of targeting a specific structural pain generator. Personally, I would have become a surgeon if I wanted to do procedures all day long. The truth is, after performing a comprehensive evaluation, educating the patient on how to get better, reassuring them, and motivating the heck out of them, I'm usually referring them for some combination of therapy, where various techniques are implemented toward achieving a restorative goal. Physical therapists use mostly physical methods to restore physical activities. Occupational therapists typically focus on activities of daily living, but there's definitely overlap and the distinction can be murky, where physical therapists work toward function and some OTs even specialize in musculoskeletal hand therapy. Rec therapy uses recreational tasks as interventions, and we already discussed speech and language pathology. Like all other docs, physiatrists prescribe therapy, but it should be a more sophisticated script than evaluate and treat. The script starts by outlining goals based on the pre-existing function, existing morbidities, and realistic anticipated prognosis. Then we use a systematic approach with the tools in our bag to get them there. We have already discussed conditioning, strengthening, equipment, etc., but it may be beneficial to discuss modalities. Modalities are passive treatments, meaning they're being done to the patient rather than them taking an active part. The modalities are the therapeutic physical agents that now are an adjunct to active treatments. These include hot and cold, electrical stimulation, manual techniques, and although less prevalent, hydrotherapy, and light-based techniques. Heat can be transferred a number of ways other than direct contact. We can apply it at various depths. Hot packs and heating pads are probably the most frequent. Then hot paraffin. Fluidotherapy is a machine that uses corn husks, radiant heat, and even hot stones. For the deep heat, ultrasound seems to be the main option that has stuck around. You can get the body cold with ice packs, aggressive ice massage, cryo units, and even vapocoolant spray. Electricity-based systems are quite prevalent. TENS units deliver small currents to the surface in an effort to distract the pain pathways. IFC TENS just does this in a different way to deliver it deeper. Iontophoresis is when you use electricity to force medication into the tissue, and neuromuscular electrical stimulation is the use of electricity to create some functional activity. This overlaps a bit with the field of prosthetics when used in devices. Therapeutic application of your hands on the patient is a broad topic with many powerful techniques that can include several categories of massage, the stuff osteopaths and chiropractors are taught, but also things like athletic taping or traction. There are indications, contraindications, precautions, and ample literature to review for all of those. For the completists, we use hydrotherapy, especially for wounds, but it is time and labor intensive. Light, magnet, vibration therapies would also fall under this world, but are less prevalent. The therapist will also tap into the patient's own various biological signals as a source of feedback for the patient to expedite their progress. Let's move on to the topic of neuromuscular medicine and quickly review what we mean when we say neuromuscular. Sensation, in teal here, begins with a stimulus in the periphery that travels through nerves and plexuses to reach the cell bodies located in the dorsal root ganglia, just outside the spinal cord. Another axonal projection goes up the spinal cord, and then synapses abound within the brain. Conversely, the motor pathway starts with a thought in the brain, an upper motor neuron crosses over and synapses with a lower motor neuron in the anterior horn of the spinal cord. The axon traverses the ventral root, plexuses, peripheral nerves, and then causes movement. This whole motor pathway is what we are going to spend our time thinking about today, so let's deepen this discussion. As you know, neurons are cells serving as the structural and functional units of the nervous system, sending messages from one part of the body to another. Structurally speaking, the majority that physiatrists deal with are multipolar, which have variably branched processes projecting in many directions for diversified input that is integrated at the cell body. The afferent pseudo-unipolar neurons have two processes which fuse during their development into one short common axon, which splits into one branch that terminates in the periphery, while the second branch heads to the spinal cord. This way, stimuli from the periphery bypass the cell body and reach the axon terminal without delay. If you slice a nerve, you'll see that it has a skin, or epineurium. Inside are bundles or fascicles surrounded by connective tissue called perineurium. The bundled axons are themselves surrounded by a matrix called endoneurium. Here we see the rootlets extending from the spinal cord and coalescing to form the roots. Wherever this happens, we call it a spinal level, such as C7 level. The ventral root joins the thickening of the dorsal root, which is called the dorsal root ganglion, to form the spinal nerve. Notice that the dorsal root ganglion is essentially sitting within the neuroforamen. Let's deviate to pathophysiology for a moment. There are two types of damage to nerves. Demyelination is the preferential injury to a segment of the myelin sheath where conduction will be affected. Remyelination can occur with shorter internodal lengths, but function will be restored. If the cell body is affected, then the entire cell dies and disintegrates. If only the axon is damaged, then the Schwann cells and axon around the injured segment degenerates, in addition to everything distal from there to the end organ. This is called Wallerian degeneration. Eventually, regeneration can occur if there's a clear path to the end organ. This is pretty straightforward for the motor neurons, but it's a different story for the pseudo-unipolar axon sitting in the dorsal root. As you can see here, only one projection degenerates while the other remains intact. So, if you were to test this degenerated segment, it would be abnormal. But if you tested this intact segment, it would appear to be normal. Let's move distally. The term motor unit refers to the anterior horn cell, its axonal projection, and all of its associated terminals, junctions, and muscle fibers. Here you see two motor neurons projecting to a muscle belly. The blue one has many neuromuscular junctions with a set of muscle fibers interdigitating between muscle fibers belonging to another motor neuron in red. Here we can see them histologically with motor end plates, axons, muscle fibers, and even the spindle in real life. An action potential causes an influx of calcium ions at the nerve terminal, where vesicles filled with acetylcholine are mobilized, docked, and primed to the membrane before exocytosing into the synapse. These vesicles have numerous proteins which we target with botulinum toxins. If acetylcholinesterase in the synapse doesn't gobble it up, acetylcholine will bind to the receptors on the muscle membrane, initiating a new action potential and muscle contraction. Remember this slide, the differential for weakness in internal medicine versus the systematic proximal to distal neuraxial approach in PM&R? So I just want to clarify what I mean when I'm talking about neuromuscular conditions, and this is why the way I teach my trainees when they're first learning. I organize the conditions based on the proximal to distal site of primary pathology. We start most proximally with motor neuron disorders like ALS. Next are the anatomical sites of lesions, such as root, plexus, or specific nerve. Polyneuropathies are next, which can be further subdivided as axonal or demyelinating. Neuromuscular junction disorders such as Lambert-Eaton, botulism, and myasthenia gravis. And finally, muscle pathology of different causes, myopathies. So starting with motor neuron disorders, they can affect motor neurons in the central and peripheral nervous systems. Both upper and lower motor neuron diseases present with weakness, which leads to atrophy and flaccidity in the lower motor neurons, when there's lower motor neurons involved. Reflexes are affected with upper motor neurons, but normal or gone in lower motor neurons. And spasticity accompany the upper motor neuron injuries. Finally, electrodiagnostic testing will only be beneficial with lower motor neuron conditions. Amyotrophic lateral sclerosis is the one I encounter most often. It is usually a sporadic progressive degenerative disorder of unknown etiology that characteristically affect both upper motor neurons and lower motor neurons, but spares sensory and autonomic function. Diagnosis isn't always straightforward, especially early in the illness when symptoms are anatomically restricted. The weakness affects mobility, respiratory muscle function, and even sometimes is associated with a pseudobulbar affect. We usually get involved somewhere at the time of diagnosis and stay through to end of life. So that's just a taste of one of many motor neuron disorders. As we move through systematic differential, the nerve roots can be affected. The term for this is radiculopathy. It presents with weakness, pain, and altered sensation in the affected myotomes and dermatomes. You can get fooled by referral patterns emanating from other places. For example, you can see sclerotomal patterns on the right, referral patterns from the gut and organs, intervertebral discs, muscle, and even facet joints. The roots themselves are fickle. In fact, one study injecting roots at various levels found a variation from the dermatomes and even side-to-side differences within the same person. So it takes some experience to distinguish these, and you'll learn so much more as you're in your rotations. Proceeding distally to the next structure, physiatrists are uniquely suited to figuring out brachial plexus pathology. This is due to a solid understanding of the anatomy, syndromes, and electrodiagnostic testing. Mononeuropathies are next, and they're particularly satisfying to diagnose and treat as we use clinical electrodiagnostic and now ultrasound modalities to accurately expedite treatment. When we're faced with more than one nerve, peripheral polyneuropathies can be characterized by their pattern of presentation. And during your time as a medical student, you saw ample diabetic and alcoholic neuropathies, which may be more of a stocking glove distribution, but there is also a multifocal mononeuropathy presentation. These can be acquired or hereditary, as you will likely see on your pediatric rotation. They can also be characterized by histopathology, primarily affecting the myelin sheath or the axons. Axonal can affect sensory, motor, or both. Demyelination can be subclassified into segmental, like GBS, versus uniform, like Charcot-Marie tooth disease. The neuromuscular junction is next on our systematic path. We can break these diseases up into sites of pathology. Presynaptic, like Lambert-Eaton and botulism. Synaptic space, issues like organophosphate toxicity. And the more commonly encountered postsynaptically mediated myasthenia gravis. Myasthenia gravis diagnosis may come up, but I don't really see these too often myself, and the treatment is entrenched in neurology's domain. But then again, there are some conditions we become well versed in just because of our training with electrodiagnosis, which we'll get to later. And I'm sorry, these were all YouTube videos and they're just not working today. Since muscle is the final organ of the motor unit, myopathies have to be considered, especially in the setting of symmetric proximal weakness. They're classified by their causes, and the most common to come to my clinic is the idiopathic inflammatory myopathies like polymyositis and inclusion body myositis. Some of you may choose to perform biopsies if you train in a neuromuscular fellowship, but all of you hope to become proficient in electrodiagnosis, as is required to be board-certified physiatrists. So what exactly is electrodiagnostic medicine? The human body's electrical discharges can be recorded, displayed, measured, and interpreted by the use of instrumentation. When disease alters the architecture and physiology of nerves and muscles, the altered observable changes in the discharges can be useful for establishing a diagnosis, monitoring disease progression, and assessing therapeutic interventions. The benefits of testing are confirming clinical suspicion, addresses the neuromuscular differential, and it guides other diagnostic testing and imaging. But it can bring more value than just diagnostic. Many clinicians are unaware that numerous studies have shown excellent recovery and return to work with non-surgical treatments when abnormalities are present on electrodiagnostic testing paired with imaging. They're also associated with statistically significant and clinically meaningful improvements in disability, prognosis, and response to treatment when compared to those who have normal tests. The testing is generally preceded by a short history and physical exam in order to generate a working peripheral neuromuscular differential. But there are shocks and needles involved. There are some people who may opt out of the test. Shocks are delivered to the body for nerve conduction testing. After the nerve is stimulated with this exogenous current, pickup electrodes elsewhere on the body display the electrical activity generated by nerves or muscles. The picture on the screen is called an evoked response. The x-axis measures time and the y-axis measures voltage. So this is what the setup ultimately looks like, but what you don't see is that I abrasively first swabbed the hand to improve contact and decrease impedance, then I stuck the electrodes on. If they're not self-adhering like these EKG tabs, then we use tape. Then I put some conducting gel down just like the ultrasound probe. And then after I dip my stimulator wand in the gel, I put it on the patient where the nerve is. When the pickup electrodes are picking up over sensory nerves, we call it a sensory nerve action potential, or SNAP. The SNAP is the sum of the axolemal depolarizations under the electrodes. It has an amplitude, onset, and peak latencies which we measure and analyze. Here are a few more. To understand what this waveform really is, you'll have to remember these action potentials are summations of all of the action potentials to each of the axons. You've learned about how these are generated by opening and closing of voltage-gated sodium and potassium channels. The nerve is a bundle of bundles of axons of all sizes. Larger ones have larger amplitudes and conduct faster. So if you counted all of them and plotted them by size in a histogram, it would look like this. Then if you took these and correlated them to voltages like they did here for a cat nerve, the result looks like a lot like an actual snap potential. In unmyelinated nerves, this propagates very slowly by depolarizing adjacent membrane. When a Schwann cells full of gooey myelin wrap themselves around the axon at intervals, you get the so-called saltatory conduction. Basically, the ions are flowing intraaxonally to neighboring nodes, conducting far faster than in unmyelinated nerves. So now you can understand that the pickup electrode attached to the skin basically works like a microphone. It's picking up the traveling wave of depolarization through the skin, and you start to see a waveform. As it propagates away, the displayed waveform changes. Now, in order to explain what happens in the machine, I had my former resident draw this, and I put this animation together for you. The stimulator delivers current to the nerve, and the action potential propagates to the hand. The three electrodes pick up the activity and feed it into a differential amplifier, which amplifies the difference between the different electrodes. The resultant signal is then filtered and converted into computer ones and zeros so it can be stored, manipulated, and measured. This can be heard through a speaker, and the evoked response can then be viewed on a display. Please hold your applause till the end. Once you have a waveform on the screen, you want to look at the latency, which is how long it took to conduct from stimulator to the pickup electrode. The amplitude, which is how beefy the response is, With good technique, this reflects the number of axons in the nerve. And then less important are the phases and velocity. When the same process is performed over a muscle belly, it's called a compound muscle action potential. The C-map represents all of the depolarizing sarcolemmae under the pickup electrode. These are bigger, so they look cleaner. Beyond the typical SNAPs and C-maps, many special nerve conduction studies and techniques have been described, and you should be familiar with them even if you don't perform them. One more common variation is the late responses, where you do the same thing as the C-map studies, but wait a little longer. The stimulation causes the action potential to travel up to the spine and back to the hand or foot again, allowing you to assess proximal segments. These include the H reflex, which is the electrophysiologic equivalent of the Achilles reflex, the F wave, and the A wave. There's another special set of tests where you stimulate something in the periphery and you pick up over the scalp or neck. These evoked potentials can arise from stimulating the skin, muscles, eyes, and ears. Neurosurgeons sometimes ask for us to do this as intraoperative monitoring to make sure they're not affecting the neuro tracts during surgery. Beyond nerve conduction studies, needle electromyography is a powerful and prevalent component of electrodiagnostic testing. A needle inserted through the skin into the muscle acts as a microphone within and displays the voltages it detects. These pictures show you what's really going on. Here's a motor neuron with all of its junctions and muscle fibers that it innervates. The spherical recording region at the tip of the needle is picking up all of these single muscle fiber action potentials and summing them up to give you this motor unit action potential. In big muscles, you're only seeing the portion of the motor unit that's near the tip. The resultant MUAP, or motor unit action potential, has amplitude, duration, turns, and phases which we analyze and interpret for clinical reasons. Motor units are voluntary activity and really just one type of finding when the needle is inserted. We also document insertional activity, which is anything that happens when we move the needle, and spontaneous activity. This is seen if the patient is relaxed and we're not moving the needle. It's the fun pattern recognition part, like recognizing AFib or VTAC on an EKG. You'll spend a lot of time staring at the screen for this stuff. And you'll be distracted by various artifacts that will fool you along the way. It's now time to hit everything else that doesn't fit neatly into the prior categories. We don't often think of osteoarthritis as a rheumatologic condition because of the lack of DMARDs to treat it, but it is probably the single most common diagnosis I see. As a result, I'm also finding rheumatologic diseases that others have mislabeled as osteoarthritis. We bring a lot of hope to all these patients by helping them get functional. We even deal with skin. There are various skin conditions we encounter. Inactivity, for example, leads to pressure sores, which you're going to become an expert in managing. Amputees get something called verrucous hyperplasia with ill-fitting prosthetic components. Even too much heating pad use leads to a condition called erythema ab igne, and you'll see every type of wound in your dysvascular diabetics. So take their shoes off, for God's sake. If survived, extensive burns can lead to contractures. They can also lead to infections and severe disability. The depth and total body surface area suggests the severity. The rule of nines is helpful in estimating it. Specific positions are better for preventing complications than others, and we can really help them get back to functional life. There's a whole world of pediatric rehab that nearly enticed me into fellowship. It was far more satisfying to me than actual peds. I learned most of my adult rehab principles during my peds rotations. There are topics specific to peds, though. Spina bifida can be benign or result in paraplegia. Accompanied by brain malformations, neurosurgical interventions might be a part of their management. Cerebral palsy describes a group of permanent disorders of the development of movement and posture, causing activity limitation that are attributed to non-progressive disturbances to the developing fetal or infant brain. CP is often accompanied by disturbances of perception, cognition, communication, and behavior, by epilepsy, and by secondary musculoskeletal problems too. CP can be classified either by the neurological presentation or the regional presentation. These kids really benefit from us as we monitor their exam through development and try to game their system. We can accommodate deformities and address issues with tone, walking, and posture. They have lots of other issues, and we can advocate for them with other clinicians who may not be as comfortable with the diagnosis. PM&R docs were pioneers in the management of lymphedema. Wound care nurses have taken on a lot of groundbreaking work, but it came actually from our field. A topic that you may not relate to PM&R, believe it or not, having a physiatrist on an organ transplant team has shown improved survival rates, work output, and quality of life. With cardiac transplant, loss of vagal inhibition to the SA node leads to high resting heart rate and blunted response to exercise. Usually there's associated pre-op deconditioning and depression as well. Women with disabilities are a long way from full integration as they're disproportionately affected by discriminatory practices. Medical and pharmaceutical research has excluded women attributed to methodological issues about the menstrual cycle, to liability concerns related to potential pregnancies. 5 to 8% of girls have physical, cognitive, emotional, and learning disabilities. More abuse, early pregnancy, and lower employment rates, lower income, less access to quality healthcare and sexuality education, more unemployed, socially isolated and deprived of social roles available to non-disabled women. Lack of access to information can prevent women with disabilities from achieving self-determination. So this is a topic that really needs to continue to be developed. They are not typically seen as wives and mothers due to fears of producing disabled children, and suffer from the not good mothers stereotypes, including oppressive policies like sterilization and criminalization. Managing and adjusting disabled females to menarche, menstruation, irregularities, and the list goes on. We need to be at the forefront of this as physiatrists. To be honest, that's all I got. That's all I got to. There's still so many things I'd love to add to this, but you get the drift. I hope this was helpful. As a bonus, I just thought I'd show you an interesting case. This was the first case that my resident, Dr. Eduardo Cruz Colon, presented to me on his first day of his first PM&R rotation at the VA. I think it's just fascinating how a physiatrist can look at the patient a little differently. So it's a 69-year-old male veteran with decreased sensation, what amounted to the T2 dermatome, axillary pain, and unintentional 10-pound weight loss. He presented with persistent burning right axillary and anterior chest wall pain, which began after a fall 3 months prior. Cardiac evaluation, of course, was performed and was unremarkable. Some dysesthesias were also present in the axilla, which radiated to the medial elbow. Symptoms were relieved with placing the right hand on his head. Other than some myofascial taut bands in the periscapular muscles, physical exam only revealed consistently decreased light touch and pinprick sensation in the T2 dermatomal distribution, meaning the axilla. Imaging was ordered to rule out an anatomical cause for thoracic radiculopathy. And I got to tell you, his whole presentation was basically, hey, this guy has chest pain. But as we got deeper into the discussion, it turned out there was some neurologic involvement. So when we got the imaging, we found that he had a large tumor, apical tumor, and it was metastatic. And this was the first time it had been found. And it was based on the physical exam that the physiatrist performed that this was figured out. So I guess the point is that, when you learn your history and your physical exam, do it. Do the entire history and physical exam that you learn on your physiatry rotation. It's been put together that way for a reason, and it's possible that no one else has done that exam for the patient otherwise. So I hope you enjoyed that little bonus section. And the purpose of this talk was entirely for medical students who want to get a real survey of the field, not just a feel-good one. And there was about 250 slides, so you definitely got all that you can from me. Anyway, hope you do go into PM&R if you got through this far. Take care.
You get asked.
Can I make a comment on your slide here?
Yeah.
Go back one. Go back one.
Yes.
Are you able to go back one?
Oh, more. Okay, sure. This one? How long were you?
Yeah, there we go.
Okay.
Sorry, I just woke up. So, so one of the things you'll see that's not on that slide, now go forward, sorry, is on the benefits of exercise, I actually don't see weight loss there. And that's an important thing to keep in mind is that, yeah, there probably is a little bit of weight loss that comes with exercise and you replace fat with muscle. So you're close, but not in the gym. And that's really important when you're doing lifestyle with your patients. If you set them up with the expectation that if they exercise more and don't make any dietary changes, they'll lose weight, that won't happen and that'll be demotivating for them. So I just wanted to emphasize that point.
I am so glad you mentioned that. I spend a lot of time on diet counseling, depending on if they're diabetic or if they're just looking at weight loss. And I tell them immediately, the science is very clear. Caloric restriction has a profound effect on weight loss, while exercise has almost none. And I say that straight to the face, because a lot of our patients, Norbury will agree with this, they have pain. And so like, well, I can't work out because, you know, my knees hurt or my back hurts. And it's like, hey, good news. That's not going to affect your weight loss. The what you're doing right before you go to bed, eating that bag of chips. Wow, that used to be me, by the way. I learned. I've lost 25 pounds, so I'm really motivated to help people. Yeah, and Norbury's half the man he used to be, I think. Right? No, I'm just kidding. All right. So I'm going to get to this slide in a moment. I want to just take a breath for me so I can drink some water. And also, basically, I'm hitting you with science because I don't want you to think PM&R is just flowers and violins, which it is. It really is flowers and violins. At this moment, as a break, do you guys have any questions that you'd like to ask me?
Just an editorial comment. Also, cupcakes and rainbows.
Yeah, I mean, after talking about Mother Nature's metformin, I felt cupcakes was not appropriate. All right.
I was just going to ask if we're going to have access to the PowerPoint after the presentation. I think it's really interesting. I would love to look it over again.
Absolutely. Okay, cool. The whole reason for this PowerPoint is so that it's all in one place. I actually started this as an intro lecture for my PM&R residents to say, hey, this is everything you're going to see for the next 3 years. What turned out to happen was the seniors found it to be a good board review too, because there's a lot of hard science in there. Yeah. So what I did was I took out a lot of slides that are deeper for you, and I've also taken out what I say a little bit so that it's a little softer in the listening category. So absolutely, I'd be happy to share these slides.
Perfect. Thank you.
You're welcome.
And for any of you who are considering coming to our residency program, this lecture is going to be given every year as one of the introductory lectures. Did I tell you that yet, Gautam?
Well, that's why we're recording it.
Well played, brother.